I just wanted to start off with a little introduction. As I say, my name's Jo Hargrave and I'm the lead midwife for East Genomics. And East Genomics is together with the Genomics Laboratory Hub and the Genomic Medicine Service Alliance. And we aim to try and collaborate to ensure that our eligible patients can access appropriate genomic tests, which are able to personalise treatment, but also provide research opportunities. So we want to try and bring that equity of access to that nationally commissioned genomic testing set out by the National Testing Directory, so that we're making sure that no matter where people live or which hospital they use, they can still access that genomic testing. And as you can see over on the right hand side here, we've got this showing a map of where all those genomic medicine services and GLHs are, and we are in the blue, which is that East region. I'm just going to show over. So we cover all the way from Derbyshire, Lincolnshire, over to Norfolk and Norwich, James Paget, all the way down to sort of East and North Hertfordshire. So we cover a huge area of the UK, but we also have other GMSAs that cover those other areas. So if you're not from this area, that is not a problem at all, but we can also put you in touch with the correct leading midwives for your region as well. So I just wanted to very briefly go back to that National Genomic Testing Directory. We really want to make it clear that this is available for clinicians and for their patients. And as I said before, it is centrally commissioned. Therefore, there should no longer be this postcode lottery whereby some hospitals can offer genetic testing and others cannot, because this is based on the most appropriate testing for each clinical indication, and which testing methodology there should be, as well as which patients are eligible for testing and who should be able to order those tests. And that's why we are here today to talk about that R445. So on the agenda today, we wanted to cover and give a real brief refresher on non-invasive prenatal testing and give that overview of the technology. And that will be hosted by our speaker, Elaine, who is a consultant scientist. And then we will be followed by Marianne Quinn, who is a specialist NIPT midwife, who will talk about the R445 pathway. And then we'll follow on with some of the practicalities of sending those samples. We will also then hopefully have time for a Q&A session. So I would ask, if you do have any questions, if you could hold them until the end of the session or place them in the chat. That would just be helpful for us to hopefully stick to our times. So very briefly, I'm aware that there may be some people on the call that have not had or been part of that screening pathway. So we really just wanted to give a very, very brief overview of what the screening in pregnancy looks like for aneuploidy testing. So we have a fetal anomaly screening programme that aims to identify babies who are likely to have a specific chromosome condition. And these are Fetal, Edwards and Down syndrome. And ultimately what we're looking at is that most have 23 pairs of chromosomes, and with Fetal, Edwards and Down syndrome, there is this extra chromosome that we have. And just to talk through the history of that screening, we can look back to the 1930s, where this all began with the identification or recognition that there was a relation of age and Down syndrome. So their increasing age with the birth of having a Down syndrome child. In the 1970s, all women aged over 36 years were offered an amniocentesis to be diagnosed with that potential baby having Down syndrome. And then this was followed by markers that were discovered through the triple and quadruple tests to identify Down syndrome. And then in the 1990s, there was the nuchal translucency marker discovered, which is looking at a measurement on the back of the baby's neck, which again increased that detection rate. This has now moved on to non-invasive prenatal testing, to where we are now, where there is an evaluative rollout. I think the main thing for this to say is that we look at this at the technology side and how much has progressed in terms of screening and diagnostic, but also just to note that there is also so much that has changed in the world of medicine and those support mechanisms for babies born with these conditions, which is fantastic. And there are multiple organisations that are there available to support not only parents and public, but also clinicians with some of the questions that you may have. So moving on to non-invasive prenatal testing, I just wanted to highlight that there are lots of benefits, but there are also some challenges with this form of testing. For example, it has improved the sort of statistical accuracy of screening. So it means that there's less people with false positive or false negative results. It means that there's a further option in pregnancy prior to diagnostic testing for women. And sometimes it can give more preparation for birth. So some people do not want to have that diagnostic test, but would like to have that indication as whether they're more or less likely to have that baby with a certain condition. And also we look at the financial benefits for trust and for patients. So women are no longer needing to go to their tertiary units for that consultation with a consultant or invasive test. They can have that blood test locally. But sometimes there's still that difficulty and those challenges that a lot of people still think of it as a diagnostic test rather than a screening test. And again, it's all about that messaging and making sure that everybody is aware that it is a screening test and would need to be confirmed by a diagnostic test if it came back as a higher chance. It does also extend that timing in the national screening pathway because of waiting for that result to come back, but also understanding that there still are false positives and false negatives from this, and some people want to maybe consider terminating a pregnancy before having that diagnostic, and it's all about that conversation that you're having with those patients. So as I've said, I really want us to have a nice overview of what NIPT is again. So it might be a refresher for some people, but also brand new information for some people on this call. So I'm going to hand over to Elaine now, who is going to talk us through NIPT. Thank you, Elaine.
Thank you, Jo. Hi, everyone. I'm just going to share my screen. Okay, is that good? Okay, great. So yeah, thank you very much for inviting me, Jo. It's great to have an opportunity to speak to you all and see how everyone's getting on with NIPT and anything we can help with, any good questions. So so my name is Elaine Holgado. I'm consultant clinical scientist at HSL, which is Health Services Laboratories, but I also, part of HSL is TDL Genetics, which a lot of people know as our name. So we sort of operate under both companies. So anyway, thanks again for inviting me. So so we're based in central London and we do all of the NIPT for this region. So I'll just show you, this is what our laboratory looks like. Yes, so the basics of NIPT. So some people will call non-invasive prenatal testing NIPT or NIPS, which is non-invasive prenatal screening. It is a screening test, as Joe correctly likes to remind everyone, and I do think it does suffer sometimes from being too accurate, that people do consider it almost diagnostic. So it's always good to remember that it's a screening test. It analyses cell-free DNA of placental and maternal origin. So it's the cell-free DNA mixed together from the placenta and the mother. And that's the purpose of the test is to assess the risk of the specific fetal trisomies that we're looking for. So yeah, so the cell-free DNA, it's a combination. We don't separate the fetal cell-free DNA from the maternal at any stage in the process. We're looking at a quantitative analysis of the total cell-free DNA to assess the risk of trisomy in the pregnancy. So we process NIPT here within our genetics department. So we also perform diagnostic testing as well. So invasive testing from amnios and CVSs by rapid qFPCR, arrays and karyotyping. So we do see sort of the full picture for some of these women, not so much with the screening programme because that gets done in more local NHS laboratories. So yeah, we have a lot of clinical scientists here who do the invasive testing, cytogenetics and molecular genetics analysis, and that can be really helpful in understanding the full NIPT results. So the cell-free DNA that's analysed by NIPT is derived from the cytotrophoblasts of the chorionic villus frons. So that's the outer layer of the CVS. Cell-free DNA can be detected from 7 weeks gestation, and it's present at a high enough level in the majority of women from 10 weeks. So 10 weeks is the minimum cut-off for the assay itself, but within the screening programme for the fetal aneuploidy screening programme, that is determined by the time the lady's had her first trimester screening. For R445, because the test can technically work from 10 weeks, then the women are eligible to access NIPT earlier through that pathway. So one of the benefits of cell-free DNA analysis is that within hours after birth or miscarriage or termination of pregnancy, that cell-free DNA is completely undetectable in the mother. Fetal cells have been found from previous pregnancies, years after that pregnancy, but cell-free DNA would never impact a future pregnancy. So this is a picture of the villus frond. So just to show you that the green yellow cells from the outside of the villus, those are the cytotrophoblasts that the cell-free DNA comes from in NIPT. It's still slightly different from when we're analysing a CVS sample from invasive testing, because the mesenchyme core of the villus frond is also analysed in invasive testing, but isn't in NIPT. So sometimes you can have situations where the outer cells are different from the inner cells. So one of the types of placental mosaicism is just where those outer cells have changed. So it's still possible to have a discrepancy between NIPT and invasive testing by CVS in some rare cases. So NIPT is, as we all know, much more accurate than other screening tests, such as first trimester or quad tests. Data from the conventional screening tests show a lower detection rate and a higher false positive rate compared to NIPT. So I think that is one of the issues of people thinking it's diagnostic. And I think at the beginning, when we were offering NIPT before the screening programme, there was even more of a sort of misconception there. So it's really important to know it is much more accurate, but definitely still a screening test. And I think one of the other advantages is that where we have a high risk or a low risk, it's much more defined, whereas with serum screening, the risk can be any numerical value. So sometimes a cut of risk might be very close to a cutoff, which might put a lady into a low risk category, but she would still feel quite uncertain because it's very borderline to to that 1 in 150 cutoff. So the testing pathway for NIPT is quite straightforward for the woman and for the clinic, we hope. So we only require one blood tube to be collected from the lady now, and this is in a specific cell-free DNA stabilizing blood tube, which we send out in our collection packs to clinics, and this is now sufficient to perform the test twice if required. There's no special treatment required to the blood other than inverting the tube a few times after it's been collected, and then it's sent to the lab by post or courier. We provide 2 barcodes in our sample collection pack. One is applied to the tube and the other to the request form, and this barcode is used to follow the sample through the whole testing process. So each pack also contains an information leaflet. So that's only in the private packs. I think for the screening programme and R445 pathways, those information packs are provided by the programmes. Once we receive the sample, we centrifuge it to separate the plasma, which contains the cell-free DNA, and then we extract the cell-free DNA from that plasma using an automated process. So this slide shows some of the equipment that we use in the NIPT process, and we're using the Illumina VeriSeq NIPT assay since last September. So we used to use a different method, but we've moved over to this Illumina method, which is much more has a much lower repeat rate, and that enables us to have a faster turnaround time as well. So the extraction of the cell-free DNA happens on this Hamilton robot in the top right, and then that cell-free DNA is treated and processed and sequenced on a DNA sequencer, and the data generated from each chromosome is analysed, and a statistical analysis is performed to determine the likelihood of trisomy. Then we create the individual patient reports, which are then sent back to the referring clinic. So this slide shows the sort of fundamental principle of how the test determines if there's a high or low risk of trisomy. So the amount of cell-free DNA mapping to each chromosome is measured, and each chromosome, because the chromosomes are different sizes, there's different amounts of DNA that map to each chromosome, but the proportion of reads that are fetal in origin compared to maternal is consistent across each of the chromosomes. So in this example, we have a 20% fetal cell-free DNA proportion and 80 maternal, and you can see that's consistent across, the first 3 chromosomes. Where there's a fetal trisomy present, you would have a 50% increase in the amount of fetal cell-free DNA, but the maternal will still stay the same. So instead of having 80-20% proportions, it becomes 80 and 30%. So we've got an overall difference in cell-free DNA from chromosome 21 of 110 versus 100%. So that's how the test works. So when the results are reported, it's either a low probability for each of the trisomies or a high probability for the chromosome with the increased amount of cell-free DNA present. Fetal sexing isn't included as part of the programme, and some information such as the fetal fraction isn't included because this doesn't affect the validity of the results. We only report results that have passed and are accurate, so there's no real need to include the fetal fraction, though it is something we do sometimes get asked about. And also we don't provide risk scores on these reports either, and I know some of the reports that people access privately will include that information, but because the screening programme is determining the performance of NIPT in this high risk group as part of the evaluative rollout, the data is going to be analysed within this group specifically, and then that would be what is used to provide any risk scores if that's something that will be included in the future. So this is an example of what our reports look like. So we include obviously all the information about the patient and the referring clinic, the result for each of the trisomies is included, and then we've got the indication. So this is an R445. We have previous pregnancy with trisomy 21. For the screening programme, we have the actual risk for the condition that they're high risk for in the referral indication. And then we have the specificity data from the test overall, but this isn't specific for the, the screening programme or the R445 data. That's just for the test performance overall. And again, we always specify on the each report that it's a screening test with false negatives and positives can occur, and include some of the reasons for those. So when interpreting NIPT results, we're often asked about the accuracy, but there's lots of different values that can be applied to accuracy. So I think the most important that we want to work out through the screening program data is about the the detection rate for the trisomies, the positive predictive value and the negative predictive value for those. So the positive predictive value refers to how many of the high risk results turn out to be present in the fetus, so it's a high risk result with an affected pregnancy, and how many low risk results are in unaffected pregnancy. So that will be really useful data when that's all been completed. So I think, yeah, pre-test, it's more useful to know about the detection rate, because if you're deciding whether to have NIPT, it's useful to know how likely it is that the condition will be picked up. Detection rate is very, very high for NIPT, so that's a good statistic. And then once the woman has a result, you want to know the likelihood that the result is correct, which relates to the PPV and the NPV. Positive predictive value can vary quite a lot depending on the prior risk, so that's why some of the information doesn't relate specifically to the screening programme or the R445 women, because we know already they are higher risk, so their positive predictive value will be higher than someone who has had an NIPT without having a prior risk. But the difference between a 1 in 150 prior risk and a 1 in 5, is still quite significant. So it's still really useful and important to stress the diagnostic test that's required after a high risk result. And also taking into account ultrasound indications, because the high risk from the screening programme or the previous pregnancy risk puts them into a high risk category already, but depending on whether there are ultrasound findings that are consistent with the trisomy is also really valuable in determining the likelihood that a high risk result is present in the baby. So another question we get asked about is the follow-up testing after a high risk result. Is it okay to do a CVS, or should it always be an amnio that's performed to confirm results? So there are some recommendations been published which tend to refer more to the risk of mosaicism. So with trisomy 13, there's a higher risk of placental mosaicism. So in a baby with a high risk NIPT result for T13 without ultrasound indications, it may be more sensible to wait for an amnio. But CVS, there's less placental mosaicism for trisomy 21 and 18, so that may be more appropriate. But it's definitely also depends on the ultrasound findings and the individual woman's and clinic's preferences and options available. So like I say, because NIPT analyses the cell-free DNA from the cytotrophoblasts from the placenta, which is placental in origin, and so is the CVS. If placental mosaicism is present, that could be impacting both an NIPT result and a CVS result. So there are lots of different types of confined placental mosaicism, which can, compound CVS or NIPT results. So the first two pictures show when you have complete fetal concordance, fetal placental concordance. So either, the placenta and the baby both don't have a trisomy, or they both do, and you can have confined placental mosaicism where one area of the placenta is affected, or the mosaicism could be fetal in origin and placental, or one can be mosaic and one can be non-mosaic. So there are all sorts of different placental mosaicism possibilities present, and it can be really hard to determine, even if you know mosaicism is present, where it's present, because you're only sampling a specific area of the placenta when performing a CVS test. So confined placental mosaicism is one cause of discordant results, and it is expected to occur in about 1% of pregnancies. So it's really important to look at all of the eligibility criteria to ensure that there's few false positive and negative results that are obtained. So things like, if the maternal mosaicism, because we're analysing the fetal and the maternal cell-free DNA, if the mum we know is mosaic for a trisomy, then that would make her ineligible. If we know there's been a demised co-twin in the pregnancy, that's an ineligibility criteria as well. Maternal organ transplant and known maternal malignancy, and these are all factors that would add cell-free DNA to the maternal blood that would impact the result. So that's the reason why these factors can cause discordant results. So if we know they're present, then that's why the lady shouldn't be offered an NIPT. But obviously, we don't always know if there's been an early demised co-twin, or maternal chromosome mosaicism, or maternal malignancy. These are things that could be present without the woman or clinic knowing that they're present. So these show that there are reasons for false positive and false negative results, and we can avoid them as much as we can when we know they're there, but they are causes. So I think this was for later, so I'll stop there for now. Thank you.
Thanks, Elaine. That's really interesting. It's always good to have a refresh on these things as well. So thank you very much. So obviously, as you can hear from that, there are different ways NIPT can be accessed via private route, through NHS screening pathways, and now through this R445. So, our focus is very much on that R445. However, again, it's just important to understand those differences. So I just really wanted to give a very, very brief overview of NIPT within the screening pathway. I'm sure the majority of you on the call know this inside out, but for those of you that don't, NIPT was introduced as a secondary screening test back in June 2021 as an evaluative rollout over 3 years, and I believe it's been extended for further, so that they can actually have a look at the statistics, as Elaine was talking about, those false positive and false negative results based on that higher chance population. There are currently 3 laboratories that provide NIPT services across England. TDL, which we're really lucky to have Elaine from, is part of the laboratory that supports NIPT for the east of England. But as we say, there are also East Midlands and the Safe Test Laboratory for the south of England. So NIPT is for women who receive a higher chance from the combined or quadruple screening test of a result of anywhere between 1 in 150 or greater, so anything up to that 1 in 2 result. And it's offered for Down syndrome, Edwards syndrome and Fetal syndrome only, and there are different ways that that is offered. If women receive that higher chance result from NIPT, a diagnostic test would be offered to confirm that result. So that is it in a nutshell from that screening pathway. We're now going to step away from that screening pathway to the R445, where women are now offered it if they have had a previous pregnancy with either Fetal's, Edwards or Down syndrome. So just to be clear, it's not part of the screening pathway, but obviously it does have differing challenges with introducing it. So I'm now really excited to invite Marianne to talk, who has been involved in that pathway where the R445 has been introduced into the National Genomic Testing Directory. Thanks, Marianne. I'll pass over to you now, if that's okay.
Great, thanks. Give me a second and I will try and share my slides. Has that come up yet, Jo?
Yes, it has.
Put it in, thanks.
Oh, hold on, sorry. It's, yeah, yes, it is now, sorry.
Joys of technology, yeah. So yeah, my name is Marianne. So I'm a specialist NIPT midwife. I work at the SAFE test at St George's, so one of the other labs that were discussed that offer NHS NIPT. So today I am going to briefly talk about the R445 pathway, like Jo had said. So this is a new test indication in the National Genomic Test Directory that offers NHS funded NIPT for women with a history of previous trisomy 21, 18 and 13. It's really important to note from the offset that although this follows a different pathway, the test is the same. So the NIPT testing that all labs are doing is identical to what you're getting already. It's just the stage that we are offering this test, the screening journey is slightly different for this cohort of women. So just first off, I'm just going to go through the rationale for why this has been added to the National Test Directory and some of the eligibility and exclusion criteria. So the reason why this has been added as a new test indication in the directory is that we know that women who have had a previous pregnancy affected with a full trisomy 21, 18 or 13 are at slight increased chance of having a recurrent trisomy in any subsequent pregnancy. So due to this, if we think about the FASP screening programme, we're talking about this 1 in 150. The priority chance for women who have had a previous trisomy sits at around 1%. So it's already putting them at that increased chance sort of population. So R445 has been added to shorten the screening journey to offer the very best screening test that we have at an earlier gestation for a sort of small cohort of women who are likely to be particularly anxious. I know with this pathway that it does differ from FASP, and that can generate some discussion. I'm hoping to answer some of the questions, and please, there will be time for questions at the end. If you have any or if you've got any, then pop them in the chat. But just first off, who is eligible is any woman who has had a confirmed pregnancy with full trisomy 21, 18 or 13. Ideally, we would want clinics to see the report so that we know it was a full trisomy and this is an appropriate test that we're going to be offering in this pregnancy. If you cannot see a report, then you can still offer R445 if the woman says that she has had a previous pregnancy affected with a full trisomy. It's available from 10 weeks gestation. This needs to be confirmed by scan. There are a few exclusion criteria. So if the previous pregnancy was not a full trisomy, so a mosaic or a translocation, she would not be eligible for R445. If a donor egg is used in this current pregnancy, on the basis that the donor egg was not used in the previous pregnancy, the priori increased chance would not apply, so she would not be offered R445. And then just the same exclusions that already apply to all those samples you're sending via the FASP pathway, and Elaine sort of went through a little bit, these exclusions remain the same, so vanished twins, maternal cancer, etc. So going on to the pathway, so the R445 pathway can be offered from 10 weeks gestation. This needs to be confirmed by scan. So all women who present with a history of Down syndrome, Edwards syndrome or Patau syndrome in a previous pregnancy should be offered R445 and offered the following 3 options. The first is no screening tests, as we offer all women. They don't have to have any screening, it's completely optional. She can go to screening, and in this case, because she has a previous history of trisomy, we can go straight to NIPT screening, or she can go for prenatal diagnosis. Okay, so it's really important to note that the offer of R445 replaces the offer of combined or quadruple screening. Women should not be offered the combined or quadruple screening, as they have a lower sensitivity than NIPT. So based on sort of what I was talking about the priori chance, putting them in a slightly increased chance, and sort of we're starting the screening journey at a different place. So these women are considered already high chance, and therefore we are going to offer them the very best screening that we have so that we shorten that screening journey for them. So for women who accept R445 and want NIPT testing, bloods, as I said, can be taken from 10 weeks up to 21 and 6. This upper cutoff, again, is in line with the FASP criteria. Gestation must be confirmed by scan. One of the key questions has been, if we can offer it from 10 weeks, when are we supposed to scan? Scanning capacity is a big issue for many trusts, which I'm fully aware of. So we appreciate that many trusts will not be able to offer 2 scans, so an early scan and then a later scan as a dating. So it may be the case that women would choose to wait for the 11+2 dating scan and be offered after this scan rather than having it at the very earliest opportunity. And the reason for this, when you're counselling, is just that if she waits that extra week, the baby's that little bit bigger, and we are more likely to see some unexpected findings if they were to be present at the 11+2 to 14+1 gestation. So why it was put in the inclusion criteria for the directory that the 10-week gestation must be confirmed by scan is that it's really up to the individual clinics when they can offer this scan, as sort of to do with your capacity issues and such. So that can be offered following the scan, and obviously, if you did this scan and we had any unexpected findings, like a raised nuchal, this would be reported in the usual way and discussed in the usual way that you would counsel a woman if there were any sort of unexpected findings on her scan. So again, one of the key questions that many clinics have asked is, are women on the R445 pathway missing out on the option of an NT measurement? And although the NT does not need to physically be measured, because that is part of the combined screen programme, any NT that is visibly large should be reported in the usual way. So next, it would be, the next part of the pathway is if a woman declines, she doesn't want NIPT testing. Oh, sorry. So if the woman declines R445, she can either go straight to prenatal diagnosis, and this would be arranged as per usual pathways, or she can decline all screening, in which case she re-enters her pregnancy journey as all women who decline screening would do. So they have their normal sickle cell and thalassemia screening and their 20-week dating scan, anomaly scan. So again, one of the key questions that was asked by many clinics is, can women choose then to have combined screening rather than the R445? And this is technically possible. Women can say, I want the combined screening, I want to enter the FASP screening programme rather than the R445 screening programme, but there'd be need to be sort of extensive counselling as to why she is wanting to have combined screening over R445, given that R445 has a greater sensitivity and detection rate than the combined screen, and given that she's likely to have an increased sort of heightened anxiety given her history. So leading on from that is the question of PAP-A, which has many of you may be burning to ask, but this is something that I've come across as a very frequently asked question. So if a woman is opting for R445 and we're saying you should not offer the combined screen, then how is she going to have a PAP-A? I think it's really important for us all to remember that the PAP-A is part of the combined screen test, which is the screening test for Down syndrome, Edwards syndrome and Fetal syndrome, not a screening test for SGA or for preeclampsia. So many trusts have brought in a test that is for PAP-A alone, which lies separately from the combined screen test, and this is really up to the clinical sort of individual clinics to decide how they best manage this. But we would say that you should manage these women as you would any woman who declines screening or is too late for the combined screening when she books for her pregnancy. And very last off from me is just some feedback that we have had. Oh, actually, I've got another slide after this, so I lie, but it's just some initial feedback that we've had from the women. So this is very, very much a new pathway that has been introduced, and not all trusts have gone live, but we have had a little bit of feedback from women, and it's been positive. So the reason we brought this test in is because we wanted to reduce that maternal anxiety. We wanted to give them answers and the best test that we can sooner. So women have come back saying they're delighted to be offered the test, that it's really sort of relieving their anxiety, getting information that little bit sooner. And other women have said that they were going to pay for NIPT privately, and we knew this was happening for ages and it never felt right. So it's great that we can now fund this on the NHS and they don't have to be out of pocket to fund it themselves. So this one is last from me, is just some of the resources that are available to support the pathway, to support you in the clinics, and also some information out there for the women that can be given. At the moment, we don't have a host for where exactly this is going to sit, but I'm hoping that all of the screening and fetal medicine clinics have been sent this via FASP, and if you haven't, then please do let us know. Either Joe, Elaine or myself will be able to send this on. So there is a pathway document which goes through much more detail than I just have about the pathway. There's an information for midwives document which goes through more of the frequently asked questions, trying to support you on how you're going to deliver this in clinics. There's also a great information for parents leaflet that's been developed that can be given to women when we're just offering R445 or after a pregnancy that has been confirmed with Down syndrome, Edwards syndrome or Fetal syndrome, so she knows what to expect in her subsequent pregnancies. There is the test directory, so please do keep an eye on this because sometimes exclusions and inclusions can change. And there's also a G-Notes entry, which I believe is going live in the next few weeks. So that is all from me.
Thank you, Marianne. I'm just going to pass over back to Elaine now, just to go through that practicalities of the form. I might just share my screen, Elaine, if that's all right with you.
Absolutely, that's easier, definitely.
And then hopefully we'll just have some time. I think hopefully Marianne and Elaine have got time after 1 o'clock to pick up on some questions that you may have as well. If not, you can always email me with those questions and we can respond back as well if you can't stay for the full session. Back over to Elaine, thank you.
Thank you. So really, like I think it's clear the pathways are different, but there's lots of similarities and overlaps. So what we've done, because we expect the sample numbers for R445 to be a lot lower than the FASP screening programme, and we already had our screening packs made for FASP, which already include the request form. So what we've done is we've sent out the R445 referral request form by email, and what we would ask you to do is to use the packs that you already have for FASP, take the blood sample as usual, everything the same, but just print off a copy of this R445 request form instead of filling in the screening programme NIPT one that's in the box. And then when the samples arrive with us at the lab, we will also change the barcode that you label the tube and the form with, because we're just going to use a different number series so that we can identify the samples by on the system in the lab, because we need to keep the data separate from the screening program and the R445, because that data gets reported to different places. So if you do ever record the lab number that's on those barcodes, just to let you know that will change. But as soon as samples arrive at the lab, we will place them both at the same time and use that barcode to follow through the process. So the process happens exactly the same way. The samples are all processed together. There's no separation between the R445 and the screening program work. So the turnaround times will be just as quick as they are now. Reports are sent back to the same email addresses that you've given us for the screening program work. So everything sort of flows through the same pathway. We just have this new request form, and it just requires you to tick the particular trisomy that the lady was affected with before to show the eligibility, but the rest of the information on that form is the same. And then is there just one more slide, I think? Yeah, so just to say that we've started, so the R445 pathway is available, ready to use now. So I know there was an expectation that it had to be ready by the 1st of April, and there was a delay, even though the labs were ready, that information hadn't all been sent out to the trust. So the individual clinic pathways weren't established. But if you're ready to send samples, then we're ready to receive them. And we have received 21 samples so far for the R445 pathway. So we know it won't be, there won't be as many samples required for this pathway, but just as a comparison, since we started the fetal aneuploidy screening program for NIPT, we've processed 11,242 samples by NIPT for that pathway. So they're both, I think, going to be really good additions to the screening program. That was it from me.
As we've said, these are the resources that are available. Also from an East Genomics perspective, we have our newsletters, because I know Ian on the call will kill me if I don't mention that we do have updates through different ways and means. So we've got our newsletters that come out. We're doing them quarterly at the moment. Obviously the East Genomics Bites sessions, which we do record and do host, so you can ask your colleagues to come back to listen to them if they can't attend these actual events. And there's also a full range of training and support on the genomics education programme for midwives, nurses and other healthcare clinicians, but I'm just biased because I'm a midwife doing this session, so it's very midwifery led. We also have a national midwives in genetics and genomics group, and this was part of the collaboration to make sure that midwives were fully supported with this new pathway. So if you're interested in joining that national MIGS, it's led by Donna Kerwin, who is the lead midwife for the Genomics England. And we have a lead midwife in each of the regions. We are all trying to host our own regional midwives in genetics and genomics. So you can either join the national team or our local teams. So please just get in touch and I can post you to the relevant people. In the East, we've got a nursing and midwifery joint links meeting, which is happening on Wednesday, the 27th of March, which is basically showcasing some of the nursing and midwifery events that are happening in genetics and genomics, and that's from 12 to 1:30. And then our next regional midwives in genetics and genomics is on the 24th of April, 12 to 1 o'clock, and you are all welcome to join that. Thank you very much. It's been a pleasure, and I hope it's been a valuable session for you all, and have a great day. Thank you very much. Oh, and there's an evaluation as well, sorry. Evaluation in the chat, please fill it in. Thank you.
Thank you all. Bye.
Bye.